So we're going to be talking about differential diagnosis of neck masses, specifically for med students. Now here I've drawn the neck, and this is the midline. Below the mandible, this is the midline. There are a few midline neck masses like the thyroid gland swelling and a thyroglossal cyst. These are found in the midline. Anything apart from midline is known as a lateral neck swelling. Okay, so anything besides this midline directly below the mandible is a lateral. The lateral area of the neck has both an anterior triangle and a posterior triangle. Therefore, swellings in the anterior or posterior could be described in clinical as a lateral swelling. Here's the sternocleidomastoid muscle, and this marks the border between the anterior triangle. See here, the anterior triangle is on the medial side, and the posterior is the lateral side of the sternocleidomastoid muscle. And the clavicle is below, where the SCM comes and attaches. And that's the anterior triangle. What are some anterior triangle neck masses? Well, the anterior triangle neck masses include a branchial cyst, a carotid aneurysm, a carotid body tumour, and also a parotid tumour. Remember, parotid tumour will present there in front of the ear, and it can also, metastasize. So here's the posterior triangle. Now let's cover the posterior triangle neck swellings. The posterior triangle neck swellings are found on the lateral border of the sternocleidomastoid, and as they're found on the lateral border, below the clavicle makes the inferior border. The first swelling is a subclavian aneurysm, in the posterior triangle. Now remember, on the sternocleidomastoid's lateral side marks the medial border of the triangle. A cystic hygroma, which is a congenital abnormality, is found in the posterior triangle. So is a pharyngeal pouch. And lastly, a cervical metastasis or a cervical rib can also be found in the posterior triangle. So the midline masses were the thyroglossal gland swelling and the thyroglossal cyst. The thyroid gland swelling can be, a hyperthyroid goiter, a hypothyroid goiter, and a euthyroid goiter, which I'll talk about soon. Okay, so those are the important neck swellings, and just remember the sternocleidomastoid and the anterior triangle and the posterior. Now let's look at a more general overview, not dependent on anatomy, but dependent on the nature of origin of the disease. So you can get reactive lymphadenopathy. This is basically swollen lymph nodes, and typically due to or related with a local infection. Okay, so these are reactive lymph nodes. This is the most common swelling. They generally can last for 4 weeks. It can be due to a local infection, and they present with local infection symptoms. How do the lymph nodes appear? They appear regular, soft to...
It's 16 hours.
Sorry about that. Soft to firm on palpation and mobile. Now, when I was talking about the general overview, you can get an infectious neck swelling. You can get an inflammatory neck swelling. You can also get a neoplastic neck swelling, and you can also get a congenital neck swelling. In fact, most medical diseases can be divided into these, or medical presentations can be divided into these categories. Okay, is it infectious, inflammatory, hereditary, neoplastic? Infectious swelling, TB. TB affects the lymph nodes, and the lymph nodes appear large. TB's clinical features present with long-standing fever, malaise, weight loss, and night sweats. So I'm still catching up. Long-standing fever, malaise, weight loss, you know, the constitutional features of TB. This patient also presents with a history of foreign travel or homelessness or contact with someone who has TB. So neoplastic causes may be metastasis from any head or neck cancer. This metastasis typically does occur to the cervical nodes, okay? And this presents with specific features. So I said head and neck cancer progresses and spreads to the cervical lymph nodes. So what are the clinical features here? The clinical features might be persistent hoarseness in the voice. Remember, these are your alarm symptoms because it's cancer, it's metastasis. Persistent hoarseness, sore throat, pain on swallowing, cough, or the patient might say that they have this sensation like they have a lump in their throat. These are all suggestive of metastatic, infiltrative head and neck cancers. Now, what's the inflammatory cause? Am I going to go on to inflammatory or hereditary? Hereditary. The hereditary cause can be a thyroglossal duct cyst, it can be a branchial cyst, and it can be a cystic hygroma. Is that how you say it? Okay. The thyroglossal cyst, as we mentioned earlier in the video, this one will present in the midline and it will move on swallowing, move on tongue protrusion. And a branchial cyst, the branchial reminds me that it's lateral, okay? It's a lateral cyst. So thyroglossal is midline, branchial is lateral, and a cystic hygroma is posterior. So this is often found congenitally. Newborns are born with this. It's posterior triangle of the neck. It's congenital. It can be found at birth or within the first 2 years of life. And it's found in the left posterior triangle of the neck. Okay? So here I'm saying at birth or within 2 years. All the neck lumps we've described, I'm going to show pictures of them at the end and talk about them individually. Now, another important way is to know whether or not the neck lump moves on swallowing and tongue protrusion. So does it move on swallowing? If yes, and on tongue protrusion, it could be a thyroglossal cyst or an ectopic thyroid tissue. A thyroglossal cyst does move on tongue protrusion. Now, if it does move on swallowing but does not move on tongue protrusion, it's thyroid. Because remember, the thyroid is also midline. So the thyroid, but also remember, thyroglossal has glossal. Glossal is Latin for tongue, glossus. So it's a tongue protrusion. Now we can get a hyperthyroid goiter, which presents with heat intolerance, weight loss, tremors, diarrhea. You can also get a hypothyroid goiter with cold intolerance, dry skin, alopecia, bradycardia, weight gain, and constipation. You investigate both of these with thyroid function tests, and the TSH is high, whereas the T3 and T4 is low in hypothyroid. In a euthyroid goiter, there is no functions with hyper or hypothyroid, and you get normal thyroid. As I promised, I was going to show you some of these videos of these neck masses right at the end of the video. So first, I'm going to show you a few lateral neck masses. So this is a lateral neck mass. So remember, lateral meant anything which was both anterior to the sternocleidomastoid and the anterior triangle, or posterior to the sternocleidomastoid and the posterior triangle. This is quite clearly a lateral neck mass in the anterior triangle, since it's in front of the sternocleidomastoid. This, by the way, is actually a branchial cyst. This branchial cyst typically does occur in the lateral neck compartment. Okay, established that's a branchial cyst. Now I'm going to show you a lateral neck mass in the posterior neck compartment, posterior triangle. Okay, this is the posterior. No, sorry, this is still the anterior. No, I'm now showing you a tumor which is once again in the anterior triangle of the neck, because you can quite clearly see it's in front of the sternocleidomastoid muscle right here. You can see it. Let me zoom you out a bit. Here, it is in the anterior. It's in front of the sternocleidomastoid muscle. This muscle running along here and this muscle running along here is the sternocleidomastoid. Okay, so this is quite clearly the carotid body tumor. This is a carotid body tumor, and the carotid body tumor occurs at the bifurcation of the carotids, and it can also be associated with other tumors. You can also get a carotid and artery aneurysm, which would be a pulsatile mass when you palpate the carotid artery. This one was what I was talking about. This is a posterior neck swelling. Just focus on this one. So this is a posterior neck swelling all the way here. This is known as a cystic hygroma. Actually, this one might be a better example. Okay, here. This is a cystic hygroma. It's congenitally present in neonates, and it's occurring in the posterior triangle of the neck behind the sternocleidomastoid muscle. It's a congenital, multiloculated, giant lymphatic lesion. It's like pretty big. It's a lymphatic lesion that can present at birth on antenatal screening or within 2 years of life. Now let's talk about two final midline neck masses. Here is a midline neck mass, and here is another midline neck mass. To differentiate both of these, I know they look very different, but one of these moves on tongue protrusion. You're right. So this one is a thyroglossal duct cyst. It commonly occurs in children. It's a midline neck mass, and it moves with swallowing and on tongue protrusion. Remember, glossal means tongue, so it moves on tongue protrusion. The thyroid goiter, which was the other image, this one only moves on swallowing and not on tongue protrusion. This is associated with hypo, and euthyroid goiter. Now that is the end of the video. I really hope you benefited from this, because I couldn't see any other videos for medical students that were concise about the differentials for neck masses. All right, thanks for watching. Take care.